Hello, everyone. I would like to welcome everyone to our webinar tonight. I see we have a full house, and this is wonderful, and I'm glad to see that we will be talking about something that a lot of people are interested in. I am Dr. Susan Rogers. I am president of Physicians for National Health Program, which advocates for single payer Medicare for all, and I'd like to welcome you to our webinar tonight on DCEs. I want to thank PNHP and National Single Payer for hosting this, and especially our organizing committee, Dr. Anna Manilow, Dr. Kay Tillow, Dr. Claire Cohen, and Dr. Judy Albert, who have done a phenomenal amount of work getting this together. Now, as you'll hear, a Trump-era proposal that could hand Medicare completely over to corporate risk interests in Wall Street is on the horizon. And this move to further privatize Medicare makes our goal of Medicare for all even more urgent. So we really need to stay on top of this so that we can continue to get the care that we all will need. Our first speaker will be Dr. Ed Weisbart, who will present an overview of the direct contract entities, and he will speak with a PowerPoint. And just to introduce Dr. Weisbart, he is a national board member of Physicians for National Health Program, and he chairs the Missouri chapter. After practicing family medicine for over 20 years at Rush Medical Center in Chicago, he moved to St. Louis in 2003 to serve as Chief Medical Officer of Express Scripts until retiring in 2010. Thank you, Dr. Weisbart, for joining us tonight, and go ahead with your presentation here.
Well, thank you, Dr. Rogers. So here we go again, right? We're here tonight because of a new scheme to privatize Medicare, to transform it from a public good into just another channel for corporate profits, where a dollar spent on healthcare is a dollar diverted away from the bottom line of Wall Street investors and others. I admit right now that direct contracting story is complicated, and that's frankly one of the differences between DCE and Medicare for all. Remember, nobody is asking us to make healthcare more complicated unless they want to hide something in the complexity. So I think the story actually starts, frankly, before direct contracting. It starts, we've been in a generational struggle. There we go. We've been in frankly, a generational struggle between viewing healthcare as a public good and viewing it as a corporate investment opportunity. Direct contracting is the newest attack on Medicare, but we should start tonight's story with Medicare Advantage. Until direct contracting came up, Medicare Advantage has frankly been the most obvious and successful push to privatize, to end traditional Medicare and privatize it. So just to unpack Medicare Advantage for just a moment, here's traditional Medicare, right? We pay our taxes and we get, and the federal government then gives us Medicare, and Medicare negotiates directly, essentially, with the physicians and hospitals. And that's traditional Medicare with maybe some Medicare managed administrators. Medicare Advantage is quite different from that. Medicare Advantage is introduces a risk-bearing intermediary between Medicare and physicians. So it's the Medicare Advantage folks who get essentially their funds directly from Medicare, and then they contract with physicians and hospitals. So we've frankly had most of our advocacy eyes on Medicare Advantage because of our concerns, and we've seen Medicare Advantage growing over the last few years, and we've not been as focused on this new attack on traditional Medicare. But traditional Medicare is frankly larger than Medicare Advantage has ever been. So that's sort of the thrust of the direct contracting entities. It's to create new risk-bearing intermediaries in between Medicare and physicians and hospitals. And that creates conflicts of interest that we're going to point out to you. Direct contracting is a concept that was begun under the Trump administration, and it's even now still in the pilot project phase within Medicare. So if we did want to intervene, it's important to do it quickly while it's a pilot. It's a pilot project introduced by the Center for Medicare and Medicaid Innovation. This is a center created under Section 3021 of the Affordable Care Act to overcome what was recognized as a problem of anti-reform inertia. So the Affordable Care Act created the Centers for Medicare Innovation and gave it the ability to do a pilot project that they can then widely apply across Medicare if Health and Human Services believes that their pilot project is favorable. In other words, it reduces spending without decreasing cost or quality, or it improves quality without increasing spending. One of those two things, while not denying or limiting coverage or provision of benefits. So that's the charter of the Center for Medicare Innovation. The key point here is that if HHS believes that one of their pilot projects meets these criteria, it can roll the project out across Medicare without going back to Congress for additional approval. They have that approval. And some of their innovations are frankly better and some are than some others. So tonight we're talking about direct contracting, and this comes in a few flavors, a few different models. I'm just going to focus a bit on two of these, the most dominant ones, I think. The first is the one that's gotten a lot of attention, which is called the geographic direct contracting model, and that's or the GEO model. This would take all traditional members, Medicare members, in a specific region, a metropolitan service area or whatever, and align them to that region's. Everybody in there would be aligned, is what they call it, to that region's direct contracting entity. This particular program, which is the one that I think most people are familiar with, is actually on pause by the Medicare Innovation Center, and it's not moving forward. There's no indication at the moment that it's going to be moving forward. There's no word about that. But the reason it's worth bearing in mind is because it's an example of an ability of the Medicare Innovation Center to literally move or align everybody from traditional Medicare into one of these corporate focused entities. Not active today, no word that it's about to become active, but it could be reactivated really at any time or something like that. But that's not on the table today, and hopefully it wouldn't be. What is more active today is what's called the Global and Professional Direct Contracting Model, or the GPDC, or GLOPRO, in case we haven't had enough acronyms lately. So in this model, your medical claims data as a patient in traditional Medicare would be used to identify who the system believes to be your primary care physician, and then automatically align you, without asking you, into that primary care physician's direct contracting entity. This program is not on pause today. There are 53 pilots going on. And then in addition to being auto-aligned, if you wanted to, you could voluntarily sign up for your primary care physician's direct contracting entity. So these DCEs have two main revenue streams, either capitation or financial risk. We'll unpack them both for a moment. Capitation can be either limited to just having the DCE capitated for primary care, or actually bear a capitation for everything in your healthcare dollar. So primary care or total care. And then the DCE pays for the healthcare from their capitation dollars, pays for the care that's within the DCE's network, only within the DCE's network via the DCE's own contracts. However, Medicare patients are completely at freedom, despite being in a DCE, are at complete freedom, this kind of DCE, are at complete freedom to go outside of that DCE. And if they do, then there's somewhere the DCE doesn't have a contract with, and so Medicare directly pays for that care, and then in some process reconciles that expense back with the direct contracting entity. So capitation is one piece of revenue for the DCEs. The second piece is financial risk and how will they manage it. So the DCE can bear risk for the costs that are either greater or less than the benchmark for their population that's been set by Medicare. And this comes in two forms. They can do the global risk, which is bearing 100% risk by the DCE, or just the professional risk, which is bearing only half of the risk with Medicare. So if they are less expensive than the benchmark, they can keep either 100 or 50% of that savings, and if they're more expensive, they bear either 150 or 100 or 50% of the overage. So the words global or professional refer to how much of the risk they share, not what they're responsible for. Both global and professional models are responsible for essentially all the services that we think of today as being part of Medicare's Part A and B. So a little funny bit of naming there. So DCEs, in my mind, are going to be under significant pressure to upcode, to get larger capitations. This means that the DCE will start by engaging primary care physicians, putting them into their networks. And then once they've done that, then Medicare capitates the direct contracting entity for the patients that are within that primary care physician's practice, either in whatever way they chose to, as I mentioned. And then the DCE is under pressure, frankly, to maximize that capitation by this system called upcoding. This is my assessment of that. Now, we don't have any information on whether or not DCEs are upcoding much at this point because they're too new. So I can't unpack upcoding as a thing that's being done by DCEs today, but the exact same pressures to upcode are long established within Medicare Advantage, so Medicare Advantage plans can get higher payments. So let me explain what upcoding is and how that works. It's all based on coding the things the physician enters when we see the patient and submit a bill. We put in diagnostic codes. We say the person has hypertension or diabetes or whatever. We put in diagnosis codes, and then these codes drive a risk score that's calculated by Medicare, and the risk score is then used to determine Medicare Advantage reimbursements and eventually DCE type reimbursements. So let me unpack this for you. Here's the way the risk score would be calculated for a healthy, find one of those, a healthy 76-year-old woman, and the hierarchical condition categories, or the HCC, is essentially the risk codes. So this woman would have no extra codes and her risk score would be 0.45, and Medicare would pay the Medicare Advantage plan in 2019, when this was developed, $4,000 per year to take care of her. Now, if that person is sicker, it's appropriate for the Medicare Advantage plan to be paid more for a sicker person, you could say. And so here's somebody, same person, but adding in some diagnoses. And if you put together those diagnostic codes, the risk score goes up to 1.03, and then that plan gets significantly more. So a plan that ignored adequate coding would be losing a lot of money. So that's sort of straightforward risk coding, but there's a big opportunity to maximize the coding and to get these codes. There's a whole industry around doing this. So for example, if I were to see somebody and code them as having obesity, that's worth nothing to the Medicare Advantage plan. But if I code them as having morbid obesity, that's worth a significant bump up in their risk coding. At the end of the day, these comparable codes more than triple what Medicare would be paying that Medicare Advantage plan. So there's an industry around getting these codes so that the Medicare Advantage plan, and I propose probably the DCEs, would be able to do the same kind of game. And Medicare Advantage has gotten really good at this. So they've been able to upcode dramatically since they started looking closely at it. And those changes have nothing to do with change in real risk. It's a big opportunity. And in fact, it's in the order of hundreds of billions of dollars for this 7-year period. The same kind of strategy wouldn't have the same kind of impact under DCEs, but still a substantial impact. The rules are a bit different, so they probably wouldn't have quite the same dollar amount, but still significant. And these are the kinds of numbers that get attention on Wall Street, which is where most DCEs are owned. So fewer than half of DCEs are owned by provider groups like ACOs and physician groups and such, but most are frankly owned by investors, either publicly traded or publicly backed. And only a handful are owned by insurance companies at this point. There's 53, 6 are owned by insurance companies, but those 6 are far and away the largest of this group. So the problem that I see with the direct contracting model is that it is a huge step forward, could potentially complete the full privatization of our public precious good called Medicare. It violates the spirit of a public health program, like which Medicare is, by driving larger corporate profits as a priority over improving our health, which Medicare is remarkably successful at. It corrodes the value, frankly, of a public health plan by creating these opportunities for profiteering. And if we want to rally behind Medicare for all, let DCE take over Medicare, the traditional Medicare, and I'm not sure what it is that we would be rallying behind. So it's a big threat to our movement. And how do I stop screen share? Okay, those are my.
Thank you so much for that wonderful explanation, Dr. Weisbart. It's true, this is a big threat to our goal of trying to get health care for everyone under a Medicare for All program. I do know that Representative Porter has joined us. I do want to make a couple of notes, and Dr. Weisbart, I will ask you some questions later, but I know Representative Porter has to leave rather quickly before the end of our webinar, so I don't want to take too much time before she gets to speak. But I do want to say that our other speakers, Trudy Lieberman, who is a contributing editor to the Columbia Journalism Review, David Lipschutz, who is the Associate Director for Center for Medicare Advocacy, and Dr. Rachel Madley, who is a staff member in Congressman Jayapal's office, will be speakers later on. I do encourage participants to post questions in the Q&A, and we will try to get to as many as we can later. We do have some questions already gotten together to ask some of the speakers. I do want participants to take a look at the chat, watch the chat. There will be announcements and links put in the chat that you will find useful for, to link to later on after the program. I would now like to welcome Representative Porter to our webinar. And I think many of us are very, very familiar with her and her whiteboard. I wish she had hope she has her whiteboard with her, but I don't know. But she represents the 45th Congressional District in Orange County, California. And before coming to Congress, she spent years as a consumer advocate and taught bankruptcy law at UC Irvine School of Law in California. Wielding her infamous whiteboard, she has become a champion for the people, and we are honored to have her as one of the panelists this evening. So Representative Porter, the floor is yours.
Oh, yes, this is why I didn't want to, I need the lights off, the bright lights. I'm so sorry, but I am about to get on. Bernard, I need you to turn these off. These that are killing me. Hang on one second, everybody.
No, we should put the computer up on it.
Yes, yes, we should have. Yes. Okay, everybody, I'm not that dark.
It's too dark.
Just a minute. Okay, everybody, I'm sorry about that. I am in a TV studio getting ready to go on Cuomo. And so I had all those studio lights on me and I couldn't see myself or see you guys. But thank you so much. I'm delighted to be with you all tonight to talk about why Medicare is so important. Specifically, we are here to talk about direct contracting entities, DCEs, and why they are such a threat to the Medicare program. Now, this might seem like a super wonky topic, but at the end of the day, we are talking about people's lives and the quality of the healthcare that they get. So I'm going to dig in a little bit to the details and highlight some of the other related initiatives that I'm working on to not just protect Medicare, but to improve Medicare. Last year, as you may all know, the Trump administration created a new pilot program in Medicare that relies on direct contracting entities, DCEs, to deliver care to beneficiaries. And this program was supposed to make Medicare more efficient, but actually it does just the opposite. Rather than allowing patients to go to providers directly under traditional Medicare, DCEs invite insurers and investors to step in and interfere with the care that Americans get. By adding in these intermediaries, the Trump administration undermined the very purpose of Medicare, which is to provide quality health coverage and increased financial security for seniors. Here's the thing. We know that traditional Medicare works. Since it was established in 1965, Medicare has been enormously successful at improving millions of older Americans' quality of life. Medicare serves approximately 1 in 6 Americans and virtually all of the 65-plus population. So given Medicare's incredible success, you might be wondering, why would anyone want to overhaul this program? And the answer, as with too many things in Washington, is the greed of corporate special interests. This direct contracting entity model is just one more example of the Trump administration's many attempts to wreck a functioning, successful, popular government program for the sake of lining the pockets of its corporate donors. In effect, former President Trump tried to sell Medicare off to the highest bidder. The bottom line for direct contracting entities is not to improve the quality of care. They drive up costs for patients to maximize their profits. And this isn't hypothetical. We know exactly what happens when insurers dip their hands into Medicare, because we've already seen that play out in Medicare Advantage. As you all know, unlike traditional Medicare, Medicare Advantage allows insurers to manage healthcare plans. The result is that Medicare Advantage costs taxpayers more money than traditional Medicare, and it provides less information for agencies and, more importantly, the American people to determine whether the program is working. When an independent government watchdog investigated Medicare Advantage, it uncovered widespread denials of care. I want to repeat, Medicare Advantage costs more money. I wish I did have my whiteboard. Medicare Advantage costs more money, is less transparent, and provides worse care. We should not open the door to more corporate abuse of Medicare. And this direct contracting entity model, piloted by the Trump administration, risks even more patients being denied the care they need and leaving taxpayers with a higher bill. It is no surprise that Wall Street investors hope to see more direct contracting entities in our healthcare system, because for them, direct contracting entities are a fantastic opportunity to rake in cash by investing early so they can eventually get bought out by insurers. Wall Street wins, patients and taxpayers lose. Not only is it wrong to let Wall Street abuse Medicare, it's wrong for Medicare beneficiaries to be auto-assigned into direct contracting entities without their knowledge and without their consent. Part of what makes investing in DCE so lucrative is that they don't have to spend a dime on marketing, unlike Medicare Advantage, which is paying Joe Namath to peddle it on TV commercials. Instead, these direct contracting entities just bamboozle Americans directly into their for-profit scheme for Medicare. Now, throughout his time in the White House, President Trump talked a lot about the wonders of capitalism. Well, I am a proud capitalist and a former business law professor, and I can tell you that two of the foundational building blocks of capitalism are consumer choice and information. And without those fundamental principles, we don't have healthy markets, and consumers are more likely to get cheated. Direct contracting entities are, in fact, anti-capitalist. And that is part of the reason that back in May, I joined 3 of my House colleagues in a letter to HHS Secretary Becerra and the acting administrator of CMS, urging them to immediately freeze the DCE pilot program launched under the Trump administration. I am going to continue to stand up against misguided plans that would decrease Medicare's quality and cost taxpayers more. Part of the reason that we elected President Biden is his commitment to protecting access to health care and to lowering its costs. Medicare is incredibly popular, and the Biden administration should do everything in its power to dismantle DCEs. Medicare has broad bipartisan support among the American people, and I know this because I represent a district that is about evenly split between Democrats and Republicans. The 45th Congressional District in California also is home to the second largest retirement community in the country. And I hear from constituents on Medicare, Democrats, Republicans, and independents alike, that they like Medicare. And I hear from people who are not yet eligible that they want the program to be there for them when they become eligible. Medicare is popular because Medicare works. And of course, there are places where it falls short. But part of being a champion for Medicare is working to build on the program's successes. We can and should improve and expand Medicare so that it's strong for generations to come. If the proponents of the Trump administration's DCE pilot are serious about strengthening Medicare, rather than dismantling it and auctioning off the pieces, I have some ideas for how they could help. House Democrats are working On passing H.R. 3, the Elijah Cummings Lower Drug Costs Now Act, a sweeping package that would allow Medicare to negotiate better drug prices, bring down costs for Americans on Medicare, and for those getting their prescriptions on the commercial market. The nonpartisan Congressional Budget Office estimated this would save taxpayers nearly $500 billion and bring down the cost of drugs by 50 to 75%. I'm proud that my bill, the Freedom from Price Gouging Act, was included in H.R. 3. And this legislation is pretty simple. It says to drug companies, if you price gouge, if you hike your prices way beyond inflation, you need to give that money back to the taxpayers who are footing the bill through Medicare. Big pharma and Wall Street investors should not be able to profit from unreasonable price hikes. And if they do, we need to hold them accountable. I am urging congressional leaders to lower the age of Medicare to 60. By lowering that age, we could expand quality care to an additional 23 million older Americans. And the data is clear. This expansion means the difference between life and death for those who would be covered. Cancer diagnoses jump when patients turn 65 because they finally have access to screenings under Medicare. So despite the general convention that younger patients are more likely to have better outcomes, a recent medical study found that there is an increased chance of receiving and surviving a cancer diagnosis in patients ages 65 to 69 compared to ages 60 to 64. Why? Because those older patients have Medicare. I am also working to end the 10% penalty that seniors are subject to for each year they delay in enrolling Medicare. To fix this, I introduced the Medicare Economic Security Solutions Act, which would cap these unfair late Medicare enrollment penalties and limit how long the penalty could be applied for. Allowing Medicare to negotiate drug prices, lowering the eligibility age, and doing away with unfair penalties, these are ways we can strengthen Medicare while keeping the core of what makes the program work. And in Congress, I'm going to keep pushing for policies that will make healthcare cheaper, easier to get, and more secure. You guys know me, I'm not going to sugarcoat it. Corporate special interests are powerful in Washington. Because of their lobbying, the House Energy and Commerce Committee failed to include Medicare drug price negotiation in its portion of the Build Back Better Act. But I do not take corporate PAC money, so I cannot be bought. I am not afraid to take corporate special interests on, especially with all of you on my side. Together, we are going to forge a healthcare system that puts patients first. Thank you so much for inviting me to be here tonight and to speak with you. I'm so incredibly grateful for all of the groups that organized this event, and I'm honored to be your partner in Congress. I apologize that I cannot take any questions, but I have to go get on CNN in the next 6 minutes. So look for me on Chris Cuomo, and thank you so much for having me. Keep up the fight.
Thank you so much, Representative Porter. I appreciate your comments, your enthusiasm, and we need more people like you, more representatives like you with your energy and enthusiasm to fight for what is fair and equitable for everyone in this country. So I really appreciate you making time to join us on this webinar.
Thank you so much.
Okay, good night. Okay. We don't have time to ask the representative any questions, but I hope that everyone can get energized from her energy and enthusiasm and her remarks. We will go on with our program, and our next speaker will be Trudy Lieberman, who is a contributing editor of the Columbia Journalism Review and also a contributor to Health News Review and the Center for Health Journalism. Trudy, are you on? There you are. Okay. There you are. Welcome.
Thank you. And I appreciate the invitation to speak about a program that I have been covering since about 1988, when I worked at Consumer Reports. And we did many of the pioneering work on looking at Medicare products, looking at how Medicare was being sold to people in California especially. So it's a program I know very, very well. And I'm very pleased to be able to talk to you tonight and impart some of the things that I've learned and some of the things that I continue to learn and have learned just in the last couple of days. I've covered this program really over the time period that Newt Gingrich said back in the mid 90s that he had hoped that his goal was to have Medicare wither on the vine. So I've always kept that in mind as I've covered this program, because everything the government seems to have done since about 1994 is to destroy what is a perfectly good social insurance program. And I use the word social insurance because we know that that's what Part A certainly is. And I think most of the people who are on Medicare do not really understand that that is exactly what it is. They just know that they need it, they like it, and it works very well for them. So I think that for the purposes of this talk, I'm going to talk about 2 letters that I got in the last couple of days from people in Indiana. I'm continuing to write a rural health column for the state of Indiana. It seems like the people in this very conservative state are really very interested in knowing what really is going on. And my columns out there have been extremely well read over the last 8-9 years, and it's very popular. So we decided to continue the column in Indiana this year. And so 2 letters came in just in the last couple of days. One was from a doctor who read the last column that I produced a couple of days ago, which was the backstory of Medicare Advantage plans. That's probably going to be the first of several I'll do during this open enrollment season. Anyway, the doctor was a nose throat specialist, and he was complaining mightily about the pre-authorizations that he had to get under these MA plans for his patients. And he said they often couldn't get the pre-authorizations that were needed for these patients that had severe sinus problems because the health plans didn't think these treatments were necessary. So these people didn't have any access to the care that they would have gotten had they been in traditional Medicare. Now, Indiana is a big state for Medicare Advantage plans, and it always has been. The insurance industry has found it a very profitable state to mine people for their plans, and that's essentially what they've done. So the doctor was very, very upset about all these pre-authorizations and could hardly wait to talk to me more about what he could do about any of this. The second letter I got was from a woman who worked in a cancer clinic in Indiana. And she said, I want to tell you about the sticker shock my patients have experienced when they find out that they're under chemotherapy and that the 20% that Medicare requires them to pay for this has to be charged to the allowable charge under these out-of-pocket costs that they have to pay under a Medicare Advantage plan. So in other words, they have a high out-of-pocket cost that they never thought that they were going to have because they did not understand how a Medicare Advantage plan worked. And the woman who wrote to me said that these cases were extremely sad. And another time she told me about a woman from Arizona had moved to Indiana, and she thought that she was going to transfer her care under a Medicare Advantage plan she bought in Arizona to Indiana. Well, of course, she couldn't do that because these are all network-based, and her doctors in Arizona were not in any network in Indiana. So this woman was really out of luck, that she really had very few options. And of course, she could have gone back to traditional Medicare, which is always an option for people. But I think most of the people who have that option are unaware of something that is very limiting if they choose that option. That they are not, except in 4 states, they are unable to buy a Medicare supplement policy without medical underwriting. And this is a very little known provision that I'm always trying to get reporters to write about, and they have to go over and over and over it with me because they don't understand it. They don't understand how Medicare works, and they don't understand what this provision means to people. They don't understand underwriting. So I have to explain all these basics to them. So if it's hard for journalists to understand this, just think about a Medicare Advantage patient who wants to go back to traditional and is barred from getting a Medicare supplement because they happen to live in the wrong state. Only 4 states, New York, Connecticut, Massachusetts, and Maine, allow people to go back and get a Medicare supplement without medical underwriting, which means that they can get a policy regardless of what their health conditions are. In other states like Indiana and Arizona and all of the rest, they cannot do that. So they have to be very determined or very sick to leave a Medicare Advantage plan. Well, are they doing that? There's new research that came out this spring that I want to share with you because I think it's worth thinking about and looking at as you think about these plans going forward and what the shortcomings are. There was a study that was published in March in Health Affairs. And the study talked about who wanted to leave Medicare Advantage plans because they were not getting proper care. And it turns out that people in rural communities were really getting the short end of the stick with these plans. And that's not surprising because these are all limited networks. And in rural areas, there are not a lot of doctors, there's not a lot of networks, and there's not a lot of places for people to go. So if a certain doctor or clinic, or maybe even a hospital, is not part of a network, someone living in rural Kansas or rural Nebraska or Iowa is not going to be able to get much care. And of course, that is not really explained to people in these areas until they get sick and they want to get care and they find their options are rather limited. So what the researchers from Brown found, and I find this very instructive. This just kind of blew me away, and it made a really good post on the California site that I write for now, that 20% of the beneficiaries in the rural areas were not satisfied with their Medicare Advantage plans because they could not get doctors and they could not get care at the same location, which meant they had to drive around their counties, these rural counties, where things are separated far apart in order to get the care they needed. So this is becoming a problem. And so they went back to traditional, and they were even in these states where they could not get a Medicare supplement. So they were willing to take the risk of not having the benefit of having the supplement pay what Medicare didn't pay just to get out of the Medicare Advantage plans. And I think that that is a statistic that is worth keeping in mind. These same researchers have also done work on how Black people and how Hispanic people fare in Medicare Advantage plans. And they don't fare too well either. And that kind of goes contrary to the advertising that we're going to see with Danny Glover and Namath if he's around this year, because the advertising seems to be geared toward people of color. And what they are trying to do is to present low-cost Medicare Advantage plans that are attractive to this population and get people hooked on these plans. But what these same researchers at Brown found was that these people were gravitating to lower quality plans because the lower quality plans had lower out-of-pocket costs. And that's what many of these people were able to afford. So they tended to sign up for these lower premium plans and with the narrow networks and just took the care that they were going to get. And so we really don't know a whole lot about the care that people in these circumstances are getting, but we do know that they are barred from getting a Medicare supplement. And I would guess, knowing that the literacy about Medicare supplement policies is so low, that many of these people probably didn't even know they had that option. And I have seen many, many sales pitches over the years to all kinds of people. And I can tell you that all of these ins and outs of how this works is never very well explained to them. And as I sit there as sort of an observer, I have to keep my mouth closed because I really can't talk and raise too many questions. But it is very frustrating to see how this really happens in real life.
Trudy,
So-
I hate to interrupt you, but I do want to move on so I can ask you a couple of questions before your time is up. And I'm wondering too, if you can turn your video on so that people could see you.
Oh, it was on, okay.
It was for a few seconds in the beginning, but then there you are.
Okay, is it on now?
It's on now. Great. Okay. One of the things I wanted to ask you is, what is your reaction to all this massive marketing campaign that's going on? I see it on TV, on print ads and other media, even with popular actors like Danny Glover, specifically targeting Black Medicare consumers.
Yeah, I mean, this is the plan, I think, of the Medicare Advantage sellers, that they realize this is a ripe market for them and they're going after them. And I've heard the Namath pitch many, many times, have written about it, and they promise the moon to these people. And it just is not what these people need to know in terms of protecting themselves. And I like to talk about, they promise them free meals and that sort of thing. What they really need is coverage for those big bills that they may have. And that's really what's left out.
Yes, unfortunately. Yeah. The other question is, what do you think about Medicare Advantage in rural communities? And what is the impact on people who live there that are often isolated from healthcare, isolated without access to healthcare, because so many hospitals have closed and resources are physically, geographically widely spaced?
Well, as I said, they are having trouble getting care. And I send them, when I write about this, I always put in the address and phone number of the state SHIP program to see whether the SHIP counselors can help them figure out what to buy. But as I say, they are sort of limited because once they've left traditional Medicare, it's going to be really hard in those states to buy a supplement if they're sick.
Yeah, I think that's one of the dangers of Medicare Advantage, is that people don't understand that it's not simple to go into traditional Medicare after that, because like you say, you can't buy a supplemental, and that your access may not be there for the pre-existing conditions that you now have.
Right. I think they just are really up a creek, really. It's very difficult for them.
Yes, it's a very aggressive marketing that, does not have patient interests in mind. And that is why single payer Medicare for all is so, so important. But thank you so much for your comments and your insight and your knowledge about Medicare Advantage and how it impacts on communities here. I'd like to introduce our next speaker, who is David Lipschutz, who is the Associate Director for Medicare Advocacy. Now, he is also a senior policy attorney at the Center for Medicare Advocacy, which is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities. He currently engages in public policy issues surrounding Medicare and related coverage as they impact Medicare beneficiaries. David, the floor is yours. Looking forward to your comments.
Thank you, Dr. Rogers, and thank you, PNHP, for the invitation to be here tonight. Some of what I said has already been covered, but at risk of being repetitive, I will go ahead and cover it again. I'm first going to talk a little bit about the work that my organization does on behalf of Medicare beneficiaries as a way to set up our experience specifically with Medicare Advantage plans, which will then in turn set up comments about how we view the direct contracting demos, particularly the geographic or geo model. And then I will return to Medicare Advantage in some closing remarks. So my organization, the Center for Medicare Advocacy, is a beneficiary or consumer side organization, a nonpartisan nonprofit law firm in many ways. We're small but mighty, and our work ranges from providing direct services to Medicare beneficiaries, to providing technical support to those who assist them, to providing education, sometimes in limited circumstances, litigation, and then the work that I primarily do, policy advocacy. The scope of services that we work on run the gamut with respect to the Medicare program, including eligibility and enrollment, addressing barriers to care, pushing for greater oversight of providers, including nursing facilities and home health agencies, exploring how Medicare works with other types of insurance. And we do this in part by supporting or opposing legislation or policy proposals, working with policymakers and officials, working in coalition with groups, and working with journalists like Trudy, who we just heard from. Among the critical and recurring subjects that we engage in, both from the standpoint of consumer and broader policy issues, is the rise of private Medicare Advantage plans and their impact on both enrollees and the Medicare program in general. Due to the nature of our work, people don't often call us when they are happy about their plan or want to brag about how well their care is being coordinated. Instead, it's usually people who are running into problems accessing their care who contact us. What we have found in our experience, backed up by some of the research, including that cited by Trudy, is that many of the problems that beneficiaries in traditional Medicare face with respect to accessing care are exacerbated, often in Medicare Advantage plans. For example, services that would be covered in traditional Medicare are either prematurely terminated by Medicare Advantage plans or not covered at all. From a consumer standpoint, there are various trade-offs and things that are attractive as far as enrollment in Medicare Advantage, including the provision of extra benefits that traditional Medicare doesn't cover, negating the need to pick up a Medigap or a Part D plan. But on the other hand, I think as Trudy just pointed out, unfortunately, many of the stories that she has heard are not uncommon. Most MA plans use a restricted network of providers, and virtually all Medicare Advantage enrollees are in plans that require some type of prior authorization for some services. And such use of prior authorization often leads to problems accessing services. As the Congresswoman pointed out, 2018 Office of Inspector General report found widespread and persistent problems related to denials of care and payment in Medicare Advantage plans. Quality of care in Medicare Advantage plans is perhaps of even greater concern. Research shows that the evidence is decidedly mixed. For example, there are generally higher rates of preventive care and screenings among MA recipients, but as noted in a 2018 New England Journal of Medicine article, somewhat counterintuitively, there seems to be no difference between traditional Medicare and Medicare Advantage plans with respect to care coordination. And several studies have flagged concerns about the quality of care received by high-need, high-cost enrollees on the basis of disenrollment rates and other measures. In other words, credible research shows that those who are more sick tend to disproportionately disenroll from Medicare Advantage plans, including the study that Trudy just outlined. That's from a consumer standpoint. From a policy standpoint, there is a growing imbalance between the Medicare Advantage and the traditional Medicare program in a number of ways, including payment. I think Dr. Weisbart outlined some of the ways that Medicare Advantage plans are maximizing their income stream and how this is costing the Medicare program more, subsidized by everyone else via higher Part B premiums. The scope of benefits provided by Medicare Advantage plans are broader than what can be provided in traditional Medicare, and that has been broadened even further by Congress and CMS to include things that are not health-related. Well, at the same time, those benefits have not been made available largely to people in traditional Medicare. Oversight of such plans has been lax, And enrollment is growing at a precipitous rate. Now, roughly 42% of all Medicare enrollees are in Medicare Advantage plans, and it's projected that just in a few years, 50% or more will be in the plan. So in short, Medicare is becoming privatized before our eyes without any real public debate about whether or not this is the direction we want the Medicare program to go in. I went on this tangent about Medicare Advantage because our experiences with and concerns about the Medicare Advantage program directly informed our views of the direct contracting demonstration. To reiterate what Dr. Weisbart outlined, there are broadly two types of direct contracting demos. I'll focus most of my time on the geographic model, the model that is currently suspended. I've been asked to talk briefly about our advocacy surrounding the GEO model, so I'm going to quickly walk through a timeline. In past years, CMMI, the Centers for Medicare and Medicaid Innovation, had put forth a solicitation for public comments and drafted documents outlining a proposal for a direct contracting program. But such proposals in the past had been so ambiguous that it was really difficult to provide any meaningful feedback and specific recommendations based upon what was offered. So we were therefore surprised when in December of last year, the geographic or GEO model was announced with a rapid ramp up, seeking entities to apply early this year, slated to begin in January of 2022. When we reviewed this announcement, our red flags flew high. Our spidey sense tingled. We went on red alert because of the way that it looked like this model in particular was importing a lot of things from Medicare Advantage that gave us pause and gave us concern. These entities were going to set up contracted networks while ostensibly still providing free choice of provider. They were entering into capitated payment arrangements. They were able to employ utilization management tools such as prior authorization. And as Dr. Weisbart noted, they would apply to broad geographic areas, targeting large urban areas with no opportunity to opt out. So you would have some urban areas that were virtually all beneficiaries in traditional Medicare would be required to enroll in one of these direct contracting entities through the GEO model, including people duly eligible for Medicare and Medicaid. They would not have been subject to even some of the basic oversight that Medicare Advantage plans were subject to, such as reporting of encounter data or medical loss ratio. And in addition to these problems, there were just a host of unanswered questions. So in short, to us, it appeared that the GEO demo appeared to turn more of the federal Medicare program over to private insurers, essentially taking broad groups of people who had chosen not to be in private plans and placing them in one without an opportunity to get out. So the same month that it came out, an independent foundation, the Commonwealth Fund, wrote a blog about this. And while they didn't take a position on the geographic model, they did outline a number of concerns, including pointing out that the model had the effect of enrolling Medicare beneficiaries into a managed care-like plan. It was important having a foundation like this weigh in, even though they didn't take a position. It went a long way towards raising alarms that otherwise would have been ignored had they come solely from groups like mine. We also tried to join the public fray. We wrote about our concerns about this in December, began talking with other advocates spanning both Medicare and Medicaid space, many of whom were concerned about this demonstration, and through various avenues, we had plans to meet with CMMI staff as a larger group and express our concerns. In January of this year, we did lead an organizational sign-on letter to the then acting Secretary of Health and Human Services, asking for this model to be suspended. And in early March of this year, the geographic direct contracting model was in fact suspended, which I think we should all celebrate as a policy victory. Now, we were not the only ones pushing back on this. There are other organizations and individuals worked through various channels. We don't want to oversell the role that we played. We were a voice in a chorus. And note, as Dr. Weisbart pointed out, the CMMI website still notes that the GEO model is currently under review. And I submit to you that pressure is needed to ensure that this program does not reach the light of day. There are some existing direct contracting models, the GLOPRO models, that are in existence now and are going forward have just started. And while we have not taken as deep a dive or a look into these models as we did with the GEO model, it appears that some of the most egregious elements of the GEO model are not in these new direct contracting models. That does not mean that they do not warrant scrutiny, and vigilance is not required. And there are a lot of concerns raised by us, in part, as Dr. Weisbart outlined, who is drawn to these direct contracting entities. I want to close my remarks by turning back to Medicare Advantage. And I think what I'm going to say is not novel, not new to this group. It doesn't break any ground that you haven't covered before. But if you are concerned about the privatization of the Medicare program, the clear and present danger in this regard is already staring us in the face, and that is, of course, the Medicare Advantage program. And my takeaway message to you is that if concerted efforts are not taken to address the growing imbalance between Medicare Advantage and traditional Medicare, the Medicare of tomorrow is going to look much different than it does today. Will really be more of a marketplace of private plans with a backup public plan and less like a national insurance program. Many of you are advocates for a single universal health care program, but many of you are also aware of the barriers standing in the way that are vested in maintaining the status quo. So assuming that we don't have an opportunity to wipe the slate clean and start from scratch, chances are that any expansion in coverage will likely have to be more incremental, and we'll have to build off of existing models. And if Medicare is going to be that model, without significant improvements, including at very least righting the imbalance between Medicare Advantage and traditional Medicare, the Medicare program will become more privatized. And if anything, will be a pathway towards Medicare Advantage for all. I'll stop there. Dr. Rogers, see if you have any questions, and happy to address more later.
Yes, I do have a couple. That was an excellent presentation, and I think your points about the threat of privatization of public health insurance is public health system is crucial, and that it does have to be addressed. So, one question I'd like to ask you is that there's been a lot of talk about incrementally improving the benefits of Medicare, especially in traditional Medicare, especially lowering the age. And one of the arguments against that is whether that will just allow more people to get into Medicare Advantage. And should that be something that we support as a step to universal health care in this country, or should we limit lowering the age, not support lowering the age for Medicare?
I think if the goal is to incrementally expand coverage through Medicare, and part of that is done through lowering the age, from where we sit, in order to avoid what you just outlined, more of a flock of people going into Medicare Advantage, we would need some additional changes to accompany the lowering of the age in order to really level the playing field between Medicare Advantage and traditional Medicare. One of the things Trudy talked about earlier was access to purchase Medicare supplemental insurance policies. Right now, under federal law, there is no right to purchase such policies for people under 65. Some states can add on to those laws, as Trudy outlined. Those 4 states have continuous open enrollment, but Medigap rights would need to be expanded so they would be truly available to all. There would have to be additional things, including what Congress is debating right now, adding a vision, hearing, and dental benefit, one of the major draws to Medicare Advantage plans now. If that was offered in traditional Medicare, that would make traditional Medicare more attractive to people. Also, I think we would like to see an out-of-pocket cap in the traditional Medicare program for Part A and B services. Now, Medicare Advantage plans right now, by law, have to cap out-of-pocket expenses at a certain rate. Traditional Medicare needs that, just like most, just like Affordable Care Act plans has such a cap. That's one of the glaring things that are missing. Absent that, Medigap oftentimes can serve as such a cap, and we need to expand access to those. So there are a number of improvements that we need to make to the Medicare program, in our view, before it is really used as a vehicle to expand coverage. Now, these things can be simultaneous, but we need to see a range of issues addressed, and that imbalance really needs to be corrected unless people are okay with Medicare Advantage for all.
Thank you for that explanation. I think that clearly defines what the issue is, and that as activist groups, we have to be sure that what we're asking for in terms of improvements will really get us to the goal that we're looking for. Another question I wanted to ask you is, where should these efforts be coming from? It's difficult to get a lot of people in Congress to support these efforts. There's a lot of social activist groups, grassroots groups, a lot of players out there. How should we organize to resolve this?
Well, I think one of the things to do would be to assemble a team similar to this panel that you assembled tonight, not trying to, inflate the importance of me or my organization, but physicians. When you all don that white coat, people pay attention to you a lot more than they do some, quixotic public interest attorney. Journalists, Trudy, who we just heard from, wrote an article not that long ago calling out journalists for not covering Medicare more and lamenting the fact that that expertise is really gone. We need more of that. We need journalists who can invest the time to learn the issues and then turn that around and explain that to the lay public. We need policymakers, members of Congress who are willing to take on large industries like the insurance industry, like these investor groups that are flocking to try to participate in these different models. And you need, advocacy organizations and grassroots. It really needs to be a widespread coalition effort in order to effectuate change. People need to stay on top of it. They need to submit comments when there's public notice and comment period. They need to be engage journalists, engage each other, and get people to talk about this as you are doing tonight.
Thank you very much for the answers and your comments in general. It's very informative. I'd like to introduce our last speaker here, Dr. Rachel Madley, who is a legislative assistant leading healthcare work for Representative Jayapal, who's the lead sponsor of HR 1976, the Medicare for All bill. Dr. Madley is a former national board member of Students for National Health Program, a member of PNHP, and she has been a longtime, non-tiring activist fighting for Medicare for All. Rachel?
Thanks so much for having me. I'm really excited to be speaking to you all tonight. And so I'm just going to follow up on pretty much what everyone on the panel has been talking about. And I think what I really want to drive home is, how do we approach solving this problem? And what I think, and David touched on this a little bit, is so important about PNHP and organizations like it is the knowledge that you have and the firsthand experience that you have of how this is going to affect patients. Even if you're not seeing the direct effects of DCEs, you are likely seeing the effects of privatization of public benefits. And how is that affecting your patients, either through the data that was mentioned by Representative Porter, or just seeing your own patients in your clinics and in hospitals. And that's something that, when you're talking to members of Congress or staffers, is really powerful, because this is a wonky issue, if you will. It gets into the weeds of policy a little bit, talking about DCEs and Medicare Advantage and things like that. But if you can really boil it down to, how is it affecting patients, and also how is it affecting your ability to provide for patients, I think that is really where it becomes crystal clear that this is something we definitely need to stop. I also want to note that, as Representative Porter and Dr. Weisbart got into a bit, this is really interconnected to all of the issues we see in our healthcare system and the insidiousness of the private sector in our healthcare system. And so while you're advocating for Medicare for all, for single payer, as our office is always continuing to do, this is related to that. Because if we have a complete privatization of traditional Medicare, that's a step back in terms of getting to Medicare for all. And so when we talk about Medicare for all, that is our long-term goal. But if you're speaking with, members of Congress, other activists, whoever, in the short term, this is something that we need to be concerned about to make sure we are not moving backwards. And so I just think the combination of the firsthand experience and understanding how interconnected all of these issues are, even with drug pricing and the influence of big pharma in our healthcare system, and is related to DCEs, because that is adding interests of big health insurance companies to our healthcare system. So just keeping that framework in mind, I think, is really helpful when thinking about how do we take all of this data, all of these policy details, and boil it down into a message that we can use to really sound the alarm that this is a problem that has to be stopped. So I am just so glad that I got to hear all of the panelists and share my thoughts with you. So thank you.
Thank you, Dr. Madley. I'm glad you could join us tonight. And I know that you have seen this problem on both sides, as a physician, medical student, and now on the legislative side, and the difficulties in trying to get all of this legislation passed so that we can get the care that we all need. I do have some more questions for our panelists, but before we get to that, I want to remind everybody to keep track of the chat. There are a lot of links there, a lot of information and messages there that you will find useful. One of the things that I think that's important after being on webinars such as this and hearing all of this such important information is that we need action steps. So that what do we do now so that we can help prevent the takeover of these direct contract entities of Medicare? It's essential that we bring attention to this to others, because this has been so much under the radar that most people know nothing about this. And they also don't know how Medicare is stealing money from the government that is going right into the pockets of private insurance companies and not to health care. So there are petitions to stop direct contract entities, and there are links in the chat for that. Fill them out and you can forward them. There's a template for you to write letters to Congress representatives and to the senators that you can send and express your thoughts about this. There is a call to action meeting on October 13th by the National Single Payer movement here, the National Single Payer Organization that helped organize this call tonight. And so if you are interested in helping develop the next steps, though, that information is in the chat. And PNHP is also having our annual meeting the week of October 18th, and this will be all virtual, and there will be activities and sessions throughout the week and the weekend if you are interested in attending that. And it includes training, learning more about what single payer is, and any information you need to help you become a more effective Medicare for all advocate. So let's move on to a couple more questions. Trudy, I want to ask you if you can, how do we talk to seniors who have signed up for Medicare Advantage, and how can we frame it so that they can understand that this really is not the best program for them?
I think when you explain the problems that result, I think they will get it. I don't have any trouble when I try to explain it to people. Once they think about that there's more to this than Joe Namath and these extra benefits, and that they understand that these out-of-pocket costs that they are going to be liable for are pretty expensive, and that there's another option that they can get. They can get the Medicare supplement policy, that they just don't understand what the range of options are. And I find that extremely disconcerting after all the work of the last several decades that some of us have done to try to educate people. It's just that somehow the industry that is pushing Medicare Advantage plans has just overtaken it. So I think it's going to take a lot of patience, but maybe a template that very simply explains what you get and what the benefits of traditional Medicare are. I think people will get it. And I do think that one thing that needs to be brought out, if you could just indulge me a second, I looked at the out-of-pocket costs for New York from the Medicare handbook that I just got. So the out-of-pocket cost, the limits, we talk about the limits that they have. These are very large out-of-pockets, actually. They range from $7,550 down to $4,900. There's a range in New York County and some of the surrounding counties. And those are pretty high, actually. Many of them are $6,000. And I don't even think people understand that they have that out-of-pocket cost on a Medicare Advantage plan. So I think we have to start with some basics, a very basic template, and explain the difference. And I think that's probably where we have to go. And I think that is not being done by the, certainly not by the salespeople, and probably only by the SHIP programs. So there has to be more than that, is what I'm saying.
Okay, thank you very much for that excellent answer to that, because I think it's difficult even for me trying to discuss Medicare Advantage versus traditional Medicare with, people that I know, and it's hard for them to see beyond the superficial advantages of Medicare Advantage versus, where the real care comes in.
Can I just add one more thing real quick? That whenever I hear people explain the difference, they always sort of apologize for traditional Medicare, saying, well, there's no out-of-pocket cap. Well, yeah, there's no out-of-pocket cap, but that's not the big thing. If you buy a certain supplement, you're not going to have much out-of-pocket costs. If you buy Plan G, for instance, as a Medicare supplement, you're going to have very minimal out-of-pocket costs. And so I think people who explain this start with the negative first on traditional plans, and that really drives me crazy when I hear that.
Okay, thank you very much for that. I do want to emphasize again the petition that is in the chat. There is a link in the chat, and I think that it's important that we all we take a look at that and we sign up with that, because that's really a very important major action step that we take, and anyone on the meeting can do that right now to stop the further privatization of Medicare. I'd like to now ask Dr. Weisbart a question about the money. What is the end game with the DCEs? How do they make their money?
That's a murky question. And frankly, the fact that it's murky may be part of the problem. So direct contracting entities increase the complexity of healthcare financing. And we got to bear in mind that literally nobody is asking to have healthcare finance made more complex. No one wants the system more complex, but in that complexity, they do make money. And I think there's, 2 or 3 key ways. The first and the simplest is the one I unpacked in excruciating detail about upcoding, and that upcoding, which is an industry for them, can drive up their capitation rates. So that's one of the most straightforward way. But then the second way, of course, is through these risk-sharing arrangements, where CMS Medicare sets a benchmark, and the DCE has to outperform the benchmark And in order to do that, there's really not a lot of things you can do to outperform the benchmark. There's only two things you can do. You can either block healthcare, right? You can either have expense is just quantity times unit price. So if they want to outperform the benchmark, they either have to reduce the quantity of healthcare or they have to reduce the unit price. So the quantity of healthcare means they have to find quiet ways to get in our way of getting healthcare, which is what we've been hearing a lot about tonight. They can't formally do it, but they have lots of shenanigans to it. So one of the first parts of how they win the benchmark game is they reduce how much care people get through tricks and things, and then forcing people into, or not forcing, but encouraging people to use the DCE network and not helping them really realize that they don't have to. So when they do those things, they make money. But I think these are relatively limited financial opportunities. And I think that fact, maybe they're not that limited, there's still billions, but that fact that they're constrained to me means that there's a whole other piece that we're not seeing overtly. And that's what Representative Porter started to allude to. I can't say with certainty that that's what's going on, but I think that's probably it. When venture capital and private equity invest the tens of billions or hundreds of billions of dollars like they're doing into direct contracting entities, they typically make those investments, turn those investments into a short-term gain by growing them, in this case, and then they sell them. So I wouldn't be the least bit surprised if the real strategy here is for the investment firms that are making the investments in it to make rapid growth and then leave and go on to the next investment thing. I think that's probably what's going on, although I can't, it's too new. They haven't done that yet, but that's what they've done in most other industries when they've sort of swarmed in. So I think it's a combination of those three kinds of things.
Thank you for that answer. That was useful information to help, get a better idea of what's going on there. I would like to ask either Trudy or David, to either one of you or both of you can respond to this question, is that since Medicare Advantage and direct contract entities are taking more and more of money out of the Medicare trust fund, will they bankrupt traditional Medicare?
David.
Well, I think the focus at this point with that question should really be on the Medicare Advantage plan. It is massive. 42% of all Medicare beneficiaries enrolled in them. When it comes to the direct contracting entities, we saw the clear threat from the geographic model that is now under suspension. It's a little more nuanced with the remaining models in play. And they just started and we don't know enough about them, not to minimize the threat on the horizon, but the threat in front of our face with respect to privatization of Medicare and threats to the funding of Medicare program is Medicare Advantage. It's simply costing us more. And from a programmatic standpoint, according to Medicare Payment Advisory Commission, has never saved the Medicare program money. This should be low-hanging fruit for policymakers to look at the spending. Dr. Weisbart outlined all the wasteful spending via upcoding. That certain measures taken to address Medicare Advantage payment would go a long way towards addressing Medicare's fiscal solvency issues. But policymakers at this point in time, or not enough of them, have the interest to do that. So in short, if things continue as they are, it's going to be unsustainable for the Medicare program. And policymakers who are concerned about fiscal solvency need to act. It's too soon to tell from our standpoint about the direct contracting entities.
Can I add one point here? It seems to me we're heading in the direction that Newt Gingrich wanted all along, which is to have Medicare wither on the vine and give everybody a voucher, move to a voucherized system. That's what was planned or talked about in the 90s when all this began to break up traditional Medicare. And I wouldn't be surprised to see that is the end game of this, that everybody would get a voucher because the reason would be we can't afford Medicare anymore because of all the reasons you gave. So here's your X dollars, you go out and buy whatever you want. And then that's the end of the social insurance program. that can happen.
Okay, thank you for that insight into that. Yeah, that's this just gets messier and messier, you know, and it gets more difficult. But another question I have, and this is to any of the panelists, is that is there anyone who has oversight of CMMI? I mean, are they really able to do whatever they want? And is Becerra going to fight and prevent them from going ahead and expanding this and destroying traditional Medicare?
Well, the Affordable Care Act created the Centers for Medicare and Medicaid Innovation and gave it pretty significant authority, including to waive most provisions of the Medicare statute. And I think, as Dr. Weisbart outlined earlier, if a given demonstration shows that it saves money without reducing quality, or improves quality without costing more, or both yields better quality and savings, that CMMI can ramp that up nationally without congressional intervention. And that is a significant authority. And most of that is without judicial review, meaning without the interference of potential lawsuits. But we're kind of a ways away from that. I mean, the GEO model is suspended. And again, I think vigilance is required to make sure that that doesn't rear its head again. This other one just started. We are a long way from the point where I think CMMI would be able to elevate that and make that national. There's going to be reporting, there's going to be data showing provided. And in the case of one demonstration relating to accountable care organizations, CMS found that it didn't save Medicare money, so they essentially were putting a stop to it. So this is not a done deal, and I don't mean to minimize any potential threat on the horizon, but certain steps have to take place between now and a point in the future when something can be escalated. So there are plenty of opportunities if people believe that this is the wrong direction to go in based on what they've seen from the way that this demonstration is rolled out, to intervene and to try to encourage CMMI, try to encourage policymakers to get involved.
Thank you for that. And that's where organizations like PNHP come in to help address that. I don't know if you had anything to add, Trudy or Rachel. One of the things too is that, I'd just like to ask too, is why Medigap plans aren't more popular to combat enrollment into Medicare Advantage. Is it just that the increased out-of-pocket expense for the Medigap plan?
People don't know about them. They've never heard about them. They just, it's a foreign concept to most people. They know about Medicare Advantage because of the television advertising. And that's basically it. If the Medicare, the sellers of Medigap plans would advertise on TV, I think that they would have a different view. People would have a different view, but nobody is presenting that to them. So it's really up to the ships to do that, if they even make it to the ships, or if they read something I wrote, or they happen to see something that David's group has put out. Because the press is not telling them. That's one way that in the old days, say 25 years ago, people knew more about Medicare and what their options were because there were a lot of reporters writing about this. And that just went away. They're not doing that anymore. And so I think we have to look at the fact that the press is complicit here too. And as David said, I've written about it. I'm going to write about it again. I keep pointing it out in most of my stories that we need to have them be Medicare hounds again. And they aren't. And a lot of the reporters, when I ask them why they're not, they say they are scared to write about it because they don't understand the program. It's very complicated. And nobody has the time anymore to sit in David's office or anybody else's office for 2 hours or 3 hours and at least understand the basics of the program. So I think that there needs to be a massive education program to the media and to see if you can break through that. Because without that, they're all only going to hear about Medicare Advantage plans until the program disappears.
I think there's a couple of other dynamics at play here too. My friends who are brokers in the insurance industry tell me that they get larger commissions when they get somebody to join Medicare Advantage than when they buy a Medigap policy. And once they sell a policy, they keep getting that commission for the rest of that person's life until they go to a different broker or change plans. So there's a huge pressure from brokers to guide people towards Medicare Advantage. And then the second thing is most people don't think they're going to get sick. Most people think we're indestructible. And so they don't look at how the copays and all that accumulates. Instead, what they look at is, well, the premium for getting joining Medicare Advantage is often free, if not very cheap, because of how overpaid Medicare Advantage plans are. They're able to offer, zero premium where I live, and certainly low premiums. And the premium for Medigap policies are larger. So if you think you're indestructible, then you're going to pick the free thing rather than spending a monthly premium. So I think you're exactly right, Trudy, that there's an absence of public awareness of this, but I think there's also some very real market dynamics that are part of the drivers of the problem.
Well, I think you're absolutely right about not gauging the risk that they have. Anybody can get sick and anybody can become very sick, even if they're perfectly healthy. And
that's why they call it a stroke, right? Because it's a stroke. That's why they call it an asthma attack, because it's an attack.
Or you get a drug that gets you in a bad state. And I think they just, they tell me all the time, I'm healthy, I don't have to worry about this. That is really a huge thing. And so when you think about a $200 premium for the month or zero premium for an Advantage plan, which one are you going to take? And I think that's what they're capitalizing on. But that's wrong-headed, in my opinion. And I assume yours and everybody else's. But they don't think about the worst that can happen, and that's really a problem.
Okay. Yeah, we all do think that, even though we know we are mortal, we don't see ourselves as getting sick. And every patient that I have seen was healthy at one time. They all were. And, so it's an inevitability, and we just have no way of predicting when we will get sick or how sick we will be. But we will, at some time need health care, and that we should, we need a system where we can access that care without going broke and getting, quality care and getting what we need without having to try to navigate a landscape that is fragmented and complicated, and no matter how smart you are, difficult to understand. As a physician, when I went to go to get a Medigap plan, I couldn't understand the landscape. So it's just difficult to maneuver. So I do want to, I think we're about ready to close here, but I do want to make sure that to remind everyone to check the chat for the links. There are many links to that. And I think the chat, and this will be recorded and this will be accessed to you later. Don't forget the action steps that we talked about. Sign the petition, the letters to your congresspeople, the template is in the chat. Don't forget about the meeting on October 13th with the National Single Payer Organization for people who are interested in helping develop the next steps. And the PNHP annual meeting the week of October 18th, which will include training and some basics about single payer if you're not familiar with that. I want to just thank the panelists who were here tonight. I think that this was a fantastic program, and I think that we all learned here. Dr. Madley, David, Trudy, and Representative Porter, who is no longer on us. But thank you so much for helping us with this webinar and help spread some education and educate those of us that we need to know this so that we can help our patients, we can help our family, we can help our neighbors, because we all are going to need this access to care at some point. So again, thanks everyone for attending. Don't forget to get those links that are in the chat so you can sign the petition and send letters to your congressman, and consider joining Physicians for National Health Program and the National Single Payer Organization. So good night, everyone, and thank you for joining us. Medicare for all, for everyone. That is what we need.